Oh, well, Craig Joseph, it is incredible to have you on the phone.
Well, it's fun to call you and catch you out. I didn't know where you were going to be.
Well, it is the holidays. I'm delivering some holiday gifts and staying far away from actual humans because my husband and I are very, very sick. And these are not the times to be around people when you are sick. So we are showing our love and gratitude from a distance.
Well, that's the smart way to go about it. Thank you for I thank you on behalf of the human population.
Yeah, yes, this COVID thing is still a thing. My goodness, our paths have crossed for years and years. Back at Epic, I remember seeing you at UGM and on campus, and everyone would point you out and say, "That's Craig Joseph. He is this incredible thought leader in health and IT. I know you're a pediatrician, and I know you've been an authority in IT for a long time." I was super, super stoked to see your book come out. I was excited, designing for health, and I was hoping to get some of your thoughts. And I know, the greater thoughts are in the book. And I just want to dig in a little bit more about the current state of design methodology, the approach that you see in regards to health IT and design, and where you think it should be, or just, you know, some of the thoughts that you put into that piece of work. And I know that is informed from your awesome career.
Well, thank you for saying all those nice things. I think time has changed some of your memories to make them slightly incorrect. I do think people were pointing me out, but they were telling you to avoid me, and
Yeah,
what they were saying, watch out for that guy.
right.
And but I'm glad that you misrecall all of these things. Yeah, we wrote a book, a colleague of mine and I, about some of the problems that we've been seeing in healthcare. And it's not just in IT; it's in designs of hospitals, and it doesn't just affect clinicians. This is affecting patients, and it's really throughout the healthcare milieu. We're talking about payers, we're talking about providers, we're talking about patients, we're talking about everyone. And the thing
Yeah,
is, what you want to do is try to apply some of the principles of design, of human-centered design specifically, in order to just make it easy to do the right thing. Right? That's
right,
that's one of our that's one chapter in the book. Make it easy to do the right thing. So why is it, if we think the right thing is for a physician to use antibiotic A, we make it easy to use antibiotics B and C, even though they're either more expensive or not as efficacious for whatever reason. It's not the right thing as decided by experts. And so, the plea from the book is, hey, we know how humans think, at least most humans think in most situations. Hey, let's go with the flow, and let's make it easy to do the right thing. Let's be transparent about how things work. Again, taking things from, just imagine the elevator, that you press the call button to get the elevator. Sometimes it has a little light that turns on when you press it, and then I did it successfully. And when someone comes 5 seconds later, they also know that you did call the elevator successfully. But without that light, what do? When the elevator doesn't come immediately, you press it again. And then you press it 5 more times. And then you're still not sure if is it broken? Is it working? And so that's kind of an example of adding transparency from a design perspective. Are there things in
right.
healthcare that we can make more transparent? Hey, I submitted that form. I think I submitted that form through the patient portal. I don't know if the doctor saw it. I don't know if I actually successfully sent it. What should I do? So, that's a technology thing. Can we make it more obvious that someone was successful in the workflow that they were trying to achieve? And so
Right.
we go through kind of chapter by chapter. We actually have a chapter called Gross. Our lawyer wasn't sure that was a good idea when she was reviewing it, but it stands for getting rid of stupid stuff. And
Oh,
not
yeah.
my terminology. It's actually the title of a paper in the New England Journal that did very well. It was the chief medical information officer at Hawaii Pacific Health just started asking people in a formal way, hey, are there things that don't make any sense in our workflows, specifically in the electronic health record, but other areas as well? And can if we can identify those, and we indeed believe that they are without merit or purpose, can we get rid of them? And she writes about nurses pointing out that a 6-month-old, when a 6-month-old was coming in for a well check, the nurse was being asked to document the status of the umbilicus. And as we all know, you kind of get a belly button when your umbilical cord falls off. And
Right.
in the first couple of days of life, that makes a lot of sense, because sometimes it can get
Hopefully we all know
infected.
that. Yeah.
Yeah. Well, at 6 months of age, it's probably not something that you need to be assessing. And
Right.
yet somehow the EHR was built for some reason to continue asking that for pretty much forever. And that was an easy fix. It's those kinds of things that that we're hoping, following some of these design principles, that we can make better, improve the lives of everyone. And again, we're not just talking about doctors and nurses and therapists, but we're talking about patients. We're not just talking about hospitals and doctors' offices. We're talking about payers and insurance companies as well.
Yeah, I mean, I'm curious on your thoughts on a couple of things. Like, we know how humans, how we think, or you said something about how our brains work, and I'm not so sure. Or right, when I think of also the different team players at work, right? Everyone doing the best they can, we think. But you've got your IT team, you've got your clinicians, you've got, people that really have different and competing priorities that are at the table with design. Like, I think of, for instance, the IT team that was so stoked once that, they're like, Bre, we have Rover deployed, and it's so great. And they had checked their box, and then when I went to the place that they deployed it, the devices were in a drawer, right? And the boxes hadn't been, whereas the design had been completed, it had been completed to specifications. When we observed providers in the wild, the actual design and practice, that human-centered piece kind of fell away. And I know you have more thoughts of that, but it's not an easy thing. Like, just getting all of the pieces to come together. I mean, I also think that we overestimate the state of technology, how not just its sophistication, but its absolute utilization, at least in the healthcare space. So I mean, it's complex, right? It's really hard. Are there some tips and nuggets, aside from just the gross methodology? It's who is, looking at what is necessary, what's not necessary, and like how we evaluate utilization in the wild. I mean, that's a lot, and so unpack it as you'd like.
Well, first of all, one should never leave one's lab or design center, right? Going out and seeing how people are actually using the tools, that's kind of crazy talk. I can't believe that you would even talk about that. It's all about checking boxes. All right,
It's all about checking the box.
Maybe that's a joke. Yeah, one of the chapters we talk about continuous improvement, and that's what you're saying, and it makes a lot of sense. Sometimes you do the best design thinking you can, and you interview the best people that you think are most representative of the folks who are going to use the tool that you're creating, and it might be great at the beginning, but when you go back a year later, you discover that things have changed. Either things around the system has changed, or now you've got a different set of users who don't work in that same way, or some information that was really essential to be collected 2 years ago is frivolous now. And so without that continuous improvement mindset of, hey, we're not done, even when we and I know you and I, this is something that we've seen a lot. You pay lots and lots of money to implement an electronic health record, and then the chief financial officer says, I'm so excited that we're done. In fact, you've just begun when you go live, right? Because it's a constant it's a constant system where you're going to have to go in and make tweaks and make changes. And so certainly walking around and seeing how people are using what you created for them is essential. And also, making sure that you get the right audience. So asking the chief of cardiology, who is surrounded by fellows and residents wherever she goes, asking her how the system should work, probably not the best decision, because she's probably not really going to be using, in this case, the technology. She has folks that do that for her. And so really looking at who are the actual users, and let's interview them and then follow them around. Sometimes if you ask people what they want, they'll tell you exactly what they want, but then you create that and it's not what they need, because
Right.
they couldn't exactly put into words or successfully tell us what they actually needed. And so a lot of times, just like you had mentioned, you have to kind of, hey, I'm just going to walk around with you. I think Jack Welch called it management by walking around. I'm not so interested in hearing what my direct reports are telling me what's going on in the factory. I want to walk around the factory and talk to the people that are creating the whatever equipment that we're producing, and get their opinion, because often that's really where the magic happens. And so yeah, we've all got lots of stories. One of my favorite stories actually happened in Madison. I took my daughter to a child neurologist, and they were using a particular electronic health record that one would imagine they'd be using in Madison, Wisconsin. And I brought her there because she was having headaches. And this example in the story is in the book. She's having headaches, and I see the nurse who is rooming us open up the EHR, and she has a drop down list of reasons for a visit. And she said, "Why are you here?" And I said, "Well, she's having headaches." And she goes, "Oh, okay." And then she goes and selects the word "other," and then she goes to a free text box next to it and types in "headache," and just kind of, yeah, goes along with it, and that's fine. But I asked her, I said, "Hey, I'm just curious, do you see a lot of kids with headaches in the child neurology clinic?" That was a loaded question because I already knew the answer was,
You're
of
like,
course, yes, we do, she said. And I was like, well, it was a little odd to me that you had to choose the word "other" from the drop-down list. And she goes, well, the word "headache" is not there. So this is what we were instructed to do.
oh wow.
So I said, well, how is that getting fixed? How have you told someone that, that probably should be there? Or, what kind of feedback have you gotten? Well, the answer was, well, I wouldn't even know how to get that to anyone, and what would
Yeah.
I do? And I've had friends who've submitted a feedback or, a ticket, and they never hear back, and it just goes into this black hole.
Yeah.
And so that's another thing. If you're going to try and do continuous improvement, well, then you have to continuously improve. And that means that you have to take feedback from people and make it easy to give feedback, and then to act on that feedback, either to fix the problem or to communicate that either this is actually not a problem. Let me explain to you why this is an important piece of information. Or say, we agree with you. That would be a terrific thing to fix. We can't fix it because
Right.
it's, there's a guideline, or there's a regulation, or costs too much money, or whatever. And even if you have to give someone kind of disappointing information, saying, hey, we can't fix your problem, even though we acknowledge it is a problem, that's much better than just deleting it and not telling them anything. Because then, of course, our end users, our clinicians and patients, are not going to give us any information, any feedback, because it's just a waste of their time.
Right. Well, I think it's classic nursing mentality too. And, some of the site visits I've done, and nurses are like, I'm no complainer. I'm not going to complain about a system. I'm just going to do a workaround. It's like, well, hey, the continuous improvement mindset, it has to be a culture that's instilled by the place that we work. And, I hope that people hear this message where, we are at a state of technology where people dream that we could be so much more advanced. And that's only going to happen when people are observing the way that technology is actually used in the wild, because there's a huge gap and an opportunity to elevate. That doesn't have anything to do with machine learning and AI. It has to do with like better design of the tools that we have. But I appreciate the continuous improvement. We think a lot about agile methodology as well, which is deployed in software development. We're doing it with our humans, where design a little bit, get it into the wild, and observe the clinicians in the wild and optimize based off of the way that people are actually using the technology. I don't know if that's precisely aligned with the continuous improvement piece, but it feels like with using that principle that you have in the book, that maybe we can win a little a few more hearts and minds in the way that IT teams practice to like really knock it out of the park in the design that's being used in the wild.
Yeah, well, that makes complete sense. We wrote the book at a very, very high level, and someone asked me, "Hey, who's the intended audience?" And the answer was, "Well, it's really the very senior people in healthcare, the C-suite and the senior directors, those kinds of folks." And often, what we've seen is that they actually have people at their institutions who are designers, who have experience and knowledge about human factors engineering and that sort of stuff, but they're not allowed to do their job, right?
Right.
Hey, I thought it would be best if we did it this way because, and then state your design principle of choice. But the head of neurosurgery didn't like that, and and then the head of neurosurgery wins. And so just kind of acknowledging that, hey, you've got some experts. The head of neurosurgery is really, really good at doing neurosurgery, maybe not so much at designing an electronic health record or designing a workflow that patients should follow when they need to make an appointment with a neurosurgeon. So letting the right people kind of just do their job is a big part, I think.
Yeah, I think you have an audience in nurse executive leadership, certainly the CNIOs of the world. I know Chime, is looking for a bigger presence for nursing at Vive and at Health. And we're working on that because the design methodology has to have nursing at the table. So I think there is an appeal for the book beyond, just CIOs, and that nursing executive leadership should look at your design theory and the approach and be applying that at the table, since nurses spend so much time with health IT, and there's definitely definitely socializing it, because boy, could we use some process improvement in regards to the technologies that are surrounding nursing workflows as well. So it's just fantastic. I'm so glad that you wrote it. I'm so glad for what you're doing in the industry. And I'm so glad to talk to you today. Thank you for your thoughts and your time.
Well, it's been a pleasure. I'm glad you got to where you're going, and also glad that you're gonna minimize your contact with other humans until you're feeling better.
All right. Well, happy holidays and take care.
Same. Thank you.